All right, we're back. We talked about the Achilles and non-insertional tears, and we spent a lot of time discussing the ins and outs of that. But people do have, especially athletes, do have insertional issues and Haglund's issues. So our panel right now is going to be talking about that. Adriana is going to be leading that discussion as the moderator. We have Induced Surgical is sponsoring this session. So thank you to Induced Surgical. Adriana, it's yours.
Okay, thank you, Dr. Parekh. I'm going to share my screen. Let's see if everyone's available to see that. Okay, so first of all, I just want to thank Dr. Parekh for this honor. I'm truly very excited to be part of this incredible initiative. So thank you also to my faculty. So I'll start with Santiago. He's an orthopedic surgeon from Colombia. Then Luis is from Mexico City, who's my partner here. And we'll have Germán, who is from Buenos Aires, Argentina. So I'm just going to give you a very brief overview so we can get started with the cases. So 6% of the general population will have Achilles pain in their lifetime. And out of these patients, a third will have insertional pain. So Haglund syndrome is comprised by a prominent posterior superior calcaneal tuberosity, also retrocalcaneal bursitis, and insertional Achilles tendinopathy. It's very common in athletes, especially in running and jumping sports. And patients will present with a triad of pain, swelling, and impaired physical performance, which will limit their sport participation. So the cause of this is mechanical overload. It's mostly an overuse injury. It's caused by excessive and repetitive habitual loading of the tendon with inadequate recovery time between training sessions. So a lot of the patients, between 60 and 80%, will describe a sudden change in their training, either in an increase in intensity or duration of their training. So, for example, running, the loads are augmented 4 to 6 times the force of the body weight on the Achilles tendon, and also it increases 8% strain along the entire length of the tendon. So both sides of the tendon, both the superficial and deep side, are at greater risk of axial and transverse compressive strains. So what we're going to see in this patient is degenerative changes within the tendon, and these can be either like a loss of parallel collagen structure, loss of fiber integrity, fatty infiltration, pretty much everything we see in other tendon degeneration. We can check the morphology of the tendon with both ultrasound and MRI. But what we consider a pathologic tendon is when we see an increase of the anterior posterior width of the tendon that is more than 6 millimeters. So we can also see osteophytes. These can also be present in patients who are asymptomatic, but however, they're more common in symptomatic patients. What we've seen though is the patients that do have pain, their osteophytes are longer. So what this means is it's size rather than the presence of osteophytes that contribute to the pain in these patients. So we can also see intratendinous calcifications. And as for the Haglund's deformity, we're going to see this in a lateral weight-bearing radiograph. And what we're going to see is this bony prominence, it impinges and causes irritation around the soft tissues. So there's a lot of different ways to measure the Haglund's deformity. There's a lot of different measurements between the Chauvet angle, the Rouge pitch angle, and the Fowler-Philip angle. However, none of these measurements are very specific or highly sensitive. So I found this in an article, which I found very interesting. So what they do is they take the XY length ratio, where the X is the total calcaneal length and Y is the greater tuberosity length. So patients who have a ratio less than 2.5 are positive for Haglund syndrome. So what they're seeing with this type of measurements is that not necessarily they have a large posterior superior prominence, but more an excessively long calcaneus that causes the impingement against the Achilles tendon. So non-operative treatment will be pretty much like in every other pathology we're going to see in sports. So NSAIDs, activity modification, rest, open heel shoes, a heel lift. Heel lifts especially reduce the amount of tendon elongation and compression at the tendon insertion site that is caused with daily activities of daily living, especially with people who do dorsal ankle flexion. So eccentric exercises, we've seen a difference now that it's better for patients if you limit the ankle range of motion when they go on their heel lowering. So it's better if they don't do complete dorsiflexion of the ankle and they just go past neutral. Also, we can do extracorporeal shockwave therapy, and this decreases the pain a lot, but the concern is it also causes pain during the treatment. So not many patients tolerate it. So the failure rate is fairly high. So it's between 50 and 60%. So usually in typist athletes, we end up with surgical treatment. So surgical treatment is issued when we have a failure of conservative treatment after 3 to 6 months. So what we do is we have two options, either open or endoscopic procedures. So we're going to start with the open debridement and decompression. What we usually do is a calcaneoplasty, a retrocalcaneal bursa excision, and Achilles tendon debridement. So the most common approach for this is a longitudinal midline incision with a central tendon splitting approach. What this allows us is a good visualization of all the pertinent structures, a minimal vascular disruption of the posterior tibial vessels and the peroneal artery, and is usually a less of a risk of sural nerve injury compared to other approaches. The only concern is scar irritation may be more prominent than the other approaches. So we can also have a lateral longitudinal incision, and this is helpful because the risk of detachment of the Achilles tendon is less, because when you go lateral, you don't detach as much as if you were to go medial, because the medial attachment is bigger than the lateral one. And the Cincinnati incision is a transference incision, and what this helps is it's better with the cosmesis of the patient, better satisfaction, and less problems with scarring. So it's better to try not to detach any of the tendon if you can, but if you have intertendinous calcifications or if you have a lot of osteophytes, you can detach a tendon, but up to 50% is what is safely tolerated. After that, you have to do the insertion. So you can either do double row fixation or 2 suture anchors, but double row suture constructs double the peak load versus single row. And they also allow early post-op weight bearing as soon as 10 days compared to just a single anchor. So complications are wide ranging. Different literature puts them at between 6 to 45%, but a recent systematic review puts them less. So between 15%. So we can have superficial wound infections, scar abnormalities, skin necrosis, hematoma, sural neuritis, or DVP. But we also have failure. So failure is the recurrence of the symptoms, residual pain, reoperation, and Achilles tendon disruption, which is pretty high. It's about 6%. So return to play in normal patients or like the weekend warrior types is about 20.7 weeks. But I found this article, which I found very interesting because it's not for the weekend warrior, it's for very highly competitive professional athletes. And it says that we have to approach this cautiously because the recovery time may be longer than in other literature, about 7.5 months for the patient to return to like their first official match. And as well, only 2/3 of the patients are able to maintain their level of activity in at least like 2 full seasons. So that's pretty bad. The other thing we can do is endoscopic procedures, and these have the advantage of addressing the pathology without the strict need for detachments. As a pros, they have fewer wound healing complications, better cosmesis, and comparable outcomes. Also, very good functional results and very high patient satisfaction. They also have a 200% increase in tendon pullout compared with an open procedure, but the thing is, when we have patients who have an extensive intratendinous calcification, the better option would be to do an open debridement because we can see the whole tendon and debride it properly. So this is not adequate for those patients who have very severe tendon involvement. The downside of doing the endoscopic procedures is, as with any other arthroscopic procedure, it's magnified. So it's very, very hard to adequately assess the amount of exocytosis that you need resected. So most of these patients will need specifically a fluoro control, fluoro after you do the exocytic resection to see that you've taken out the acute, like the appropriate amount, because we've seen the failures are very, they go hand in hand if you don't resect enough. You also have a risk of accidentally causing a detachment of the Achilles tendon. So if you do, when do you do augmentation in this patient? Well, if your debridement threatens the structural integrity of the tendon, or you have patients with a high level of activity that have an increased risk of double detachment, then you do an augmentation. So as I've said before, a double root suture is the most successful technique because it doubles the peak and allows earlier weight bearing. So endoscopic procedures, the downside of these are they're very technically demanding. They require a longer operative time, and they have a very high considerable learning curve. So as for the techniques, I'm not going to go into much detail, but I found these two articles which have very good images, and they explain the techniques very well. So the first one is by Jordi Vega, and this technique, they don't detach a tendon. They do one suture anchor, and then with 4 sutures, and then they approximate the tendon to the excision. So it augments the insertional site of the tendon. And then the other one is by Jorge Acevedo, and then this is like the more traditional. So it's a percutaneous 2 double row technique, like a speed bridge. So complications are still pretty high, 4.1. Failure is a lot less, 1.8, but return to play in these patients is cut in half compared to the open procedures. It's about 12 weeks. So other additional procedures we can also do are the FHL transfer. This should not be done primarily in all patients. It's just for patients who have a severe degeneration of the tendon. Usually patients who are older, they have a greater amount of degeneration, inflammation, and overall percentage of tendon involvement. There's also the new tendency to try to do minimal or open dorsal closing wedge osteotomies like the SADC. So the SADC, the thing that it does is it tilts the posterior tuberosity anteriorly, so it impinges less, and it also reduces the lever arm of the Achilles tendon. So it reduces the verticalization of the calcaneus and eliminates the pressure on the anterior aspect of the tendon, and then it decreases the tension on the tendon as well. So it's very exciting, very new, and I'm just hoping to see what the rest of the faculty thinks of this, but I'm going to hand it over to Santiago so we can start our cases.
Thank you so much. Just want to be sure that I can share my screen. I think you're still sharing your screen. Okay, let me check.
I think I stopped. So you're all set, Santiago. I'm going to hand it over to you now.
Let me check. Can you see my screen right now?
No.
No, not yet.
Not yet.
There, no, no, it's okay.
Is it?
Yes.
Let me check. And my video, right here. Okay, I think I'm done. Well, thank you so much for the invitation. Thank you, Dr. Parekh. Thank you, Adriana. I'm so proud to be here and share some ideas with you guys. So when talking about the Haglunds Insertional Tendonitis, we have to make a question for us, and what's different with the athletes' patients. Although athletes are expected to have an early recovery, it must be understood that their expectations in returning to their regular sports activities are high. Therefore, it should be noted that a minimum of time is needed for biological healing, and their return to their usual practice must wait until the process is completed. The rehabilitation training is more demanding, which reduces the time to return to sports. After 6 months of conservative treatment, the athlete remains symptomatic. A surgical intervention is indicated, as Adriana was telling us. It is mostly the surgical intervention that these kind of patients are going to need. The options are calcaneoplasty, the SADC calcaneal osteotomy, the gastrocnemius lengthening, open debridement, and tendon reinsertion and augmentation plasty. The risk of an insertional rupture of the Achilles tendon is higher in these athletes when facing a Haglunds insertional tendonitis. This is a 25-year-old man with a history of 1 year of retrocalcaneal right foot pain. He plays tennis professionally and was diagnosed with an insertional Achilles tendonitis. The physical exam shows a well-aligned foot, tenderness at the posterior heel, and mild thickening of the Achilles tendon. In the last 10 months, the patient has been conservatively treated with shoe gear modification, eccentric exercises, and heel lifts. The patient remains symptomatic, and in the last 3 months, he's unable to perform sports activities. Images show an enlarged calcaneal tuberosity. The mechanical effect is an impingement of the retrocalcaneal bursa and Achilles insertion during dorsiflexion of the foot. This is frequently seen in athletes who practice running, jumping, or climbing sports. The pain and swelling at the posterior heel results in impaired physical performance. The tendon, in this case, has minimal degenerative changes, so the decision here was to perform an endoscopic calcaneoplasty. The potential advantages for the endoscopic calcaneoplasty are low rate of complications, shorter recovery time because of less edema and pain control, precise decompression of the calcaneal tuberosity, and prevention of over-resection. The limitations here are the presence of an extensive degenerative changes. This means that the Achilles tendon has greater than 50% of involvement, a large calcification at the Achilles insertion, or the presence of a bony spur at the posterior aspect of the calcaneus. In this situation, an open debridement and reattachment of the Achilles tendon is required. Removal of a sufficient amount of bones is essential for a good outcome. For this reason, the use of intraoperative fluoroscopic control is needed. However, no clear guideline of the amount of bone that needs to be excised during calcaneoplasty has been established. This is another case. This is a 34-year-old boxer with a 6-year history of retrocalcaneal pain who remains symptomatic after multiple conservative treatments. The X-ray shows a bony spur and a small calcification. The MRI shows extensive degenerative changes at the distal Achilles tendon and retrocalcaneal bursitis. The pathological changes seen in the affected tendon are alteration in collagen fibers, tendon atrophy, secondary to decreased tensile loads, cartilage-like changes at the tendon insertion, and calcification that is thought to be an adaptation process. The Achilles tries to increase the surface area to decrease the mechanical loads in a unit area. In this case, a longitudinal midline incision is made over the posterior aspect of the heel. The distal tendon is exposed and an open-like anatomy is made. The diseased tendon is debrided and any calcification resected. The retrocalcaneal bursectomy and the resection of the Haglund's prominence are made. A double row technique is used to ensure a strong reattachment of the tendon. A technique is ended by closing the paratendon with a 3-0 absorbable suture. The MRI after 12 weeks of surgery shows a complete integration and a healthy tendon at this time. And once the physical therapy has been successfully completed, the patient returns to sports activities. And this is my last case. This is a 27-year-old woman with a history of 1 year of retrocalcaneal pain. Factors related to tendinopathy can be intrinsic, like structural or anatomical lower extremity conditions. In this case, this patient has a cave varus deformity. There are another factors and intrinsic ones like overuse, poor training methods, advanced age, diabetes, rheumatological disorders, medications, obesity, and inappropriate footwear. In this case, this patient started running 2 years ago without professional training. Images show the presence of Haglund's deformity, calcification at the level of the tendon insertion, retrocalcaneal bursitis, and calcaneal spur and edema. The choice in this case was to perform an open debridement of the affected tendon, resection of the calcaneal prominence and calcifications, retrocalcaneal bursectomy, and tendon reattachment. Although the MRI of 12 weeks post-op shows a successful intervention of the tendon insertion and edema resolution, the patient remains symptomatic and unable to return to sports activities. The question here is, what went wrong? Should I have corrected the subtle capillary deformity in the surgical technique? This is something that we can discuss later on. After the surgery, the patient is immobilized and in plantar flexions for 2 weeks, and then a removable walking boot is used, and gradually weight bearing is started. At this time, active range of motion is performed, and after 4 weeks of surgery, patients are allowed to return to sports activity gradually. This is what I wanted to share with you guys. Thank you again for the opportunity, and I hope to have a nice discussion later on.
I actually have two questions, guys. One is, can you make a speed bridge endoscopic? And who has experience with that from the panelists?
The answer is yes, you can do it, but I have no experience doing it endoscopically. So, but the answer is yes. A lot of people can do it in that way.
All right. And do any of you guys do the Zadek osteotomy MIS, minimally invasively? And if so, what do you guys think of it?
Not in my experience, no.
Also for me.
Yeah.
Not for me.
No. Okay. All right. Thanks, guys.
Santiago, I have a question for you. On that third case, why did he use lateral extended, like an L incision instead of the straight midline? Or what are you for doing?
Yeah, I used to do that kind of incisions like a couple years ago, but not anymore. I prefer the midline incision. That kind of incision has some troubles with the horizontal cut, so I don't use it anymore.
Okay, perfect. Thank you. So we're going to go on to Luis and his cases, if that's okay.
Right. Thank you. I would like to thank Adriana for the invitation, Dr. Parekh. Thank you very much for this invitation. So I'm Luis Hermida from Mexico City. I'm going directly to the cases. So this is a 48-year-old male active runner, 6 days a week, not an elite sportsman, no other diseases, and shoe wear is difficult because of the bump. Chief complaint is 1 year, 3 months, pain after running 10 minutes and 24 to 48 hours afterwards. Sharp pain on the back of the heel while using everyday shoe wear. Lately, he has pain every day despite being treated with physical therapy and no running. He stopped running for 6 months now. And I also checked the gastrosoleus shortening, but he had nothing evident. So this is the MRI where we can see some bone edema, not a really bad Achilles, but there's a little bit of bursa. You can see it, it's not very bad, but we can see it clinically with a bump like this. So we decided to do a resection of the lump bump there and a very, very small detachment of the tendon. It probably would be like 10, 15%. We always do this with a fluoroscopy. We can see this. Okay, take a little bit of bursa also. And our post-op protocol for this kind of surgery is a 2-week non-weight bearing, 4 weeks with a boot with some wedges. Physical therapy started at 6 weeks in this guy. The patient returned to running 4.5 months after the surgery. Mild discomfort in the heel that has been wearing off since then and due to stretching. So this is, we picked this because as Santiago said on the late case, there was no Achilles degeneration, not a big bursa, but it was an exostosis that was giving problems to the patient. So this second case is different, 57-year-old male. Although they're not young and do a lot of, sports. He's a runner 3 days a week, but he also plays tennis 2 days a week, very active. With a height, I like to highlight this because he's very tall and a little bit heavy. Severe pain on the back of the heel. His chief complaint is 10 months ago, started with this pain. Severe pain on the back of the heel, swelling. Sometimes it's impossible to walk or even weight bear, and has done physical therapy for 8 months now. This guy had a total knee replacement 3 months ago, okay? And also has a contralateral Achilles in a non-insertional fashion. So he's very, very limited. So I like to share this. This is an MRI of bilateral ankles where you can see a non-insertional Achilles. And this is the Achilles we're treating now with bone edema, a very large bursa, and some degeneration of the Achilles. Here we can see it. Very, very extensive degeneration on the Achilles insertion. And this is a lateral where we can see this, the way it's having some irritation, and also the degeneration of the Achilles insertion. So we decided to do a central incision. Here we see it. I always like to, like put a little mark where the pain is the most. We can see this is the foot. We go in a very center incision. And first we go and take out all the calcifications that it's in the tendon. Afterwards, we do the exostosis of the posterior surface of the calcaneus, like we see it in here. Right now, what we do is we take out the bursa, very important, and we do the debridement of the inner part of the tendon, which is very large. I don't like to deattach a lot, but probably 40% of it. I check it all the time with a Thompson sign and also look at the tension of the tendon. With this rasp, I do smoothing of all the surfaces on the lateral and medial side. I like to palpate this and see if there's a prominence. This could be risky because when you go and smoothen more and more, you always feel something. So let's be careful with this. And then I go with a double row, very easy. In this case, I don't use a transfer, flexor altius longus, which I do a lot, but I didn't choose it in here because it was a rather healthy remnant Achilles, and I didn't deattach that much. So we do this. We also use vancomycin and do this in a very classic way, So the post-op protocol is 3 weeks non-weight bearing, 4 weeks with the boot with wedges heel insoles, which I started to take out every week. Physical therapy starts 6 weeks post-op, and he returned to jog 4 months post-op. I don't push them to do it that quick in these cases because he's a little bit heavy, and I'm afraid of the detachment of the Achilles, and contralateral Achilles is being treated in a conservative way. The third case is a 63-year-old male, so it's getting higher, healthy, but intense runner, 7 days a week. He's been running for 40 years now. Not competitive, but those 5 kilometers a day since 40 years ago, okay? So that's a lot of heel pain. on the back of the field after running. He says that the pain can last 3 or 4 days, difficult to wear some shoe wear. No gastrosoleus shortening. I don't have an MRI of this case. I just want to show this. This is a very, very big calcification. And what we do is exactly as the same case, just be able to detach all the Achilles in order to give this exostosis, this calcification, a way to go out. Like we see it in here. And then we go and see now the posterior side of the calcaneus. We also do debridement, very, very generous debridement of the tendon. And do the calcanectomy. We see it in here. We take it out. Also the bursa. And we also go and do the double row. Although he's more than 50 years, I saw a lot of good tendon and didn't decide to do a flexor hallucis longus transfer in this case. So this patient, I left it 3 weeks non-weight bearing, 4 weeks with a boot with wedges, physical therapy 6 weeks, and he began jogging 4 months and now running 5 months post-op. So this is the way I normally do this. I choose a flexor hallucis longus transfer only when there's a very degenerative Achilles insertion, or when it's degenerative related to antibiotics, which we see a very bad tissue quality. And this is the way we treat these patients. Thank you very much for this invitation.
Perfect. I have a couple of questions for you guys, just to do it like a break before Herman's case. So does your, Santiago kind of got into it earlier, but does your post-op protocol vary if it's a weekend warrior versus an elite athlete, and how so? Like, how does it vary depending on how much activity does patient have?
Is that for me, the question?
Yes, for everybody actually.
Okay. It depends a lot of how healthy is the Achilles. For me, these patients, they are over 40. So I try to take care of them. And it depends also on how much Achilles I did have to deattach. That's why I use two-week protocol, non-weight bearing. And in an older guy, I do 3 and sometimes 4 weeks. It depends on that. We know that the double row is very, very secure to let the patient go weight bearing very early. There are people that weight bear on the same week. So it depends a lot on the age for me and the quality of the tendonite attached.
Yes, I think the same. It's important, the quality of the tendon, but I'm used to use double rows of anchors. So perhaps that's allows me to let the patients to walk early. So perhaps for me, I use 6-8 weeks, perhaps 2 weeks without wearing until I take out the stitches with the boot, and I allow him to start walking with the boot. And in his feeling well, I take out the boot. I really use 6 or 8 weeks, only that in post-operative, not so much. But it's important, what I say, the decision always, it's important taking care of how is the tendon when you look it inside the surgery. That is very important for me also, at least.
Yeah, the things that I do is quite similar, but there's another thing that we have to trust in, and that's it, the kind of implants that we are using to fix the tendinopathy. When we do the double row technique, we have to trust in the implants, and that allows us to give the patient the opportunity to walk earlier than if you have another kind of technique. Also, if you are doing a calcaneoplasty, there's another scenario that those patients can walk earlier than the ones that we have to debride the insertional tendinosis. So, but the time, the biological time has to be completed, and the patients have to return to sports activity once the biological time has been completed.
Okay, one more question for you guys along the same route. Is age a factor for you guys? Taking into account a lower bone density, like what is the oldest patient? We saw Luis's patients were kind of old on the older range. Do Germán or Santiago have like an age limit, or just thinking about the lower bone density for these implants to work appropriately?
Don't take. Sorry. No, you start. I don't take so much care about the age. It depends how it pains and what activity does the patient do. Perhaps because now you have patients of 50 years, of 60 years that make a lot of sports. So I don't take so much attention to the age, but yes, to the activity of the patient, for me.
Yeah, I have the same idea. You have to treat the tendinopathy. You have to treat what the patient has. And it doesn't matter the age. I always do the same thing. I give them the opportunity to recover.
In my case, yeah, I do look at as I said, the quality of the tendon. But just 6 weeks ago, Adriana and I had a patient which I had to use this rubble roll technique. And the bone, which I was inserting the anchors, was so soft that changed my mind. I left her 6 weeks non-weight bearing because they could go in without any drilling. You know this. It has happened to everybody. So I do change my way of thinking of the recovery and post-op protocol regarding the bone quality, the Achilles quality. This guy that was 63 had a very good bone. So I agree with you. It's probably not a matter of age, but of quality of the tissues. Yes, thank you.
Good.
Okay, perfect. And one last question. If you do have a patient that has really poor bone quality, do you ever supplement with vitamin D or along those routes, or just rely on non-weight bearing for the fix?
Yes, I find it very useful, Adriana. And not only with these kind of patients, but in all the kind of patients, I find it very useful, and I use it very often.
When I see a bad bone quality, I go with the transfer. I secure my reconstruction with that, and I also use vitamin D. Thanks to you.
I'm a firm believer in vitamin D. I did my training with Mark Meyerson, so he just supplemented everyone. So for my personal practice, I supplement almost all my patients. But yeah, specifically with these kind of, the calcaneal bone is very porous. So I'm just wondering if everybody else is just constantly just thinking it's going to fail, or just trying to do something else to help your patients have better bone quality. So it's not just me. Thank you for letting me. So we're going to go on to Germán for your cases. Okay. So I'm going to turn this over.
Let me see it. I want to share my screen. Let me see. Wait, took. Let me wait a minute. I have to put this down. Well, thanks, Adriana, for the invitation, Parekh. I have a long case, and I want also Luis and Santiago to help me here. So this is my patient. He's 28 years old. He practices sports 5 days a week. He likes running. He comes to the office with the insertional Achilles tendinopathy, tenderness palpation, within 2 centimeters with bone insertions, posterolateral pain. These X-rays, MRI, And here we have my patient. Luis, what do you think about this? How would you start doing this? With these x-rays, MRI?
Yeah, that's very good. Now I see it very clear. It looks like very straightforward, unless on my mind that after failing conservative treatment, this guy needs to do something. I would like to ask something. Does he has any gastrosoleus shortening?
No.
Not really, yeah.
Silver
Well,
just good.
Okay.
And he was a fit boy. He was not fat. He was fit. He ran 6 weeks, 6 days a week.
So I would do what you already saw I do. So I will try to do a surgical procedure in which I do a resection of the bursa, resection of the bone. Although the Achilles, it doesn't look that bad, really. It's not that bad. But on the lower right image, it looks a little bit. So in this case, I would do that, yeah.
Open surgery.
Yeah.
Santi?
Yeah, I would do the same. And my approach would be that this patient has some calcification of the insertion of the Achilles tendon. He has some edema of the posterior aspect of the calcaneus. Of course, he has a Haglund's deformity, but I do see some kind of compromise of the Achilles tendon at the insertion. So I would go for the open debridement, resection of the posterior aspect of the calcaneus, and a double row technique to reattach the tendon.
Well, good. Well, this is important. What Adri told us, some information about the x-rays for me are very important because you can see intertendinous calcification, spurs, 68 to 80% in patient with pain, nearly 45 with patient without pain. Remember that the Haglund deformity is not a set of pain, intersectional place of the Achilles. These are two angles that I found. We speak today early with Adriana, perhaps the folio field angles. It's not so reliable, but it's important perhaps to understand something. This, you have to draw an angle. You have to draw two lines, one along the plantar surface of the calcaneum tuberosity and a line that goes to the tangent to the most prominent point along the posterior aspect of the tuberosity. Normal from 45 to 70 degrees, more than 75 degrees, you have to consider it a normal. There are lines that I try to look in the x-rays are the parallel pitch lines by Pavlov. Here I have to draw two lines, one that goes along the most prominent portion of the plantar surface of the calcaneal tuberosity. The second line starts to the most posterior aspect of the subtalar posterior facet. If the Haglunds goes over this line, it's considered positive. If it is under this line, you consider it negative. Perhaps these two X-ray angles and lines are not so specific, but perhaps what I tell you before, they helps you just to understand where I have to make the resection. On the RMI, remember that the bone marrow edema is always associated with pain. And here I find something that Nicholson describes. He develops a graded system for Achilles tendon pathology based on the RMI, in which the severity was associated with prognosis for not surgical treatment. The type 1, you will find a thickened tendon, 6 to 8, and no uniform degenerations. Type 2, also thickening of the tendon, more than 8 millimeters, but with uniform intramural degeneration involving less than the 50% of the width of the tendon. And type 3, diffuse thickening of the tendon, more than 8, but the uniform intramural degeneration involving more than the 50% of the width of the tendon. So he gets to this conclusion that grade 1 requires surgery only the 13% of the patients, but grade 2 and 3, nearly between the 90s and the 70s. So just to remember, if you find grade 1, you may say the patient that perhaps with non-surgical treatment, he will go good, but perhaps if you find grade 2, and grade 3, you perhaps need to be prepared to explain the patient that a surgery will be needed. So this is our patient. I think it was in a grade 2, grade 3. So that was the idea for me. So getting back to the patient, the x-rays and the MRI, I said what Luis told me, non-operative treatment, 6 months of not operative treatment. I got the boy each month in my box office telling me that he continued with pain, but I say him that the paper said I have to wait 6 months. So I start with physical therapy, eccentric exercise, ice, heel lifts, change the footwear, telling him to stop running, anti-inflammatories. I give him extracorporeal shockwave therapy, but he continued with pain. So I have to go to the operative treatment. That's what I ask you. You tell me what to do, which approach, and what do you use to fix. Both of you give me your opinion. I will show you what I did. I make a longitudinal midline incision. Remember, it's good visualization of the structures and result in minimal vascular disruption. I get to the tendon, I split it, I get to the bone. There I make the resection of the Haglund. I prepare it. I use a double row construct. I prepare it. I put the tendon over the bone. Like we all know, I was very happy with this. When I was nearly getting away the boot, he came to my office, pain, pulling discharge. Yeah, yes, Luis. And pain at the weight bearing. He was walking with the boot and he came with crunches, with purulent discharge, and a lot of pain. This was his incision. So I decided to take him to the surgery room, make a toilet, take all the anchors, take resection of bone, resection of the Achilles tendon, and this was the situation. Toilet, sampling, SAMs resistant to these antibiotics, sensible to these ones. So we work with the infectology department, 15 days of intravenous treatment. Then they changed to oral prescriptions for nearly 21 days. And now, this is my skin situation. Luis, could you help me? Santiago, what do you do now? Because I was very afraid. This I have to speak with Dr. Arrondo, my boss and friend, try to help me because it was the first time I have this problem. Luis, I need you.
Is it in pain? Still in pain?
Not pain now. Sorry, I forgot to tell you something. I take all the things and I put him a plaster in echinus all this time just to thinking in not losing the echinus and the tendon. So this was the situation, this skin, no pain, no signs of infection.
If he has no pain, I think you have to wait until everything looks better. The infections, of course, has to be treated. And if the patient has no pain, probably I won't do anything else right now. If the patient wants to go back to some sports activity and I understand that he's not going to be able to do much, I will go for an endoscopic FHA transfer once everything is clear and the infection is gone.
Well, good. Thanks for your advice. I need to call you before this. Luis?
First thing, I feel you, brother. This is terrible. I've been
Imagine that he was a runner. I had to tell him not to run anymore.
I know.
He was starting getting fat because he was very fit, and then he's not running. He was angry, getting fat.
So my question is, when you say I took everything out, I understand you took the anchors, the sutures, and how much tendon was debrided, more or less? I mean, okay.
I will show you a good question because I will show you something. This was the tendon and the bone.
Get you now. Okay. So,
Wait.
Yes. So I completely agree with Santiago. I will wait for this. Unfortunately, I have dealt with this more than once, and mine and from others, we have to say that it happens to you. I mean, it does. So I will wait to everything to be cold, bring a infectology service with me. And whenever this is really cold, really, FHL transfer is perfectly an option. But if this is really free of infection, I can go a little bit further. There's some things that Mafuli say about late reconstructions that can be done, but this is insertional, so it's a little bit more difficult. If I see in a young patient who wants to run a bone that has no osteomyelitis, there's no infection on the tendon, I will do the transfer, but I will try to do a descent, because there's nothing better than having your own Achilles or your own system. So this is what I would do. Wait a little bit. The transfer, it's perfect. We have to do it. But
also, if it is a runner?
Yeah, if he's a elite runner, he will feel this lack of FHL. But okay, it's a good question. He has a catastrophe here.
So, yeah. That's what I'm asking you. I think that he was a runner. All the incision was cold, but the patient was hot with me. I know. And he's saying, I want to run again. It's my passion.
I understand. There's this, I haven't done it, but I can tell you, there's a transfer of the peroneus brevis that fully reported that the patients returned to a very good sports activity afterwards. So, and I'm speaking about a neglected Achilles rupture. So it is a little bit different because this is insertional, but that's what I would do. I won't leave the idea of probably descending it after doing the transfer.
Well, I will show you what we did with the Vasco. He was a runner. I think about the VHL, but as I read in runners, sports, so I was very afraid with this patient, so I want to be sure. So what we did, we use a BA advanced. This is something we published 2 years ago with the Vasco Rondo and Leandro Castola, in which we take 17 anatomic specific legs. We take the distance, the minimum and the maximum distance from the perpendicular distance from the apex of the medial malleolus until the myotendinous complex of the medial gastrocnemius. The minimum distance was 14 centimeters. The maximum was 20. So the average distance was 16. So we did this. We make the small incision, 16 centimeters from the medial malleolus. There we found the medial complex, myotendinous complex. We repair the vein. We get to the fascia. We make the B. We use titanium anchors. We use the same holes, but we put it in different directions just to get more bone. There we take the tendon after doing the B. You will see here, oh, sorry, wait, sorry. I want to show this, how the tendons goes down.
Beautiful.
There, as we see, we put the tendon near to the bone. We put the bone in echinos, the foot. We use 2 anchors on the second row to fix it to the bone. You see how it's there? We put it near to the bone. After doing that, we suture in the proximal incision the fascia. This was the result on MRI.
Looks beautiful.
Tendon.
Really.
Yeah. So I tried to look some information about this before doing this. Remember, why you have to do is always you do a longer incision, not now with the percutaneous treatment. Remember, you can use it for tendon gaps from 4 to 6 until 10 centimeters. This is very important. Perhaps the branches of the V have to be 1.5 times the size of the defects. What is better here is that you don't need to use another tendon to make the surgery. It decreases the size of the muscles, but keeps strength and function. That's why I decided this for this patient that was running. I want to run again. From the flexor hallux, it's a tendon long and durable. This is what you tell me, Luis. It's 1.4 times stronger than the peroneus brevis, and perhaps I won't use it for insertional problems. It's twice strong as the flexor digitosus. It has two advantages. One mechanical is that it goes in the same vector of the Achilles tendon, and one biological because it provides blood to the diseased Achilles tendon. The problem is that you need to use another tendon and also decrease the plantar flexion stress. That's why we use the other technique. And if you want to read this is a paper that brought Cesar Netros and Coles that they get to the conclusion that the BY advancement is comparable to the FHL transfers for the periodic treatment. Thank you for your attention.
Very nice case.
Yes.
That was wonderful.
Thanks for your opinions, amigos.
We have 2 minutes left. I have a question for all of you guys. You have a patient that you do surgery on, a Haglund's resection, Achilles debridement, and a repair. 8 months later, they're still having pain. What do you do?
Sorry, I don't hear you. Could you repeat it?
8 months after the surgery, they're still having pain at the insertion site. What do you do?
And what surgery we did to the patient?
Resection of the Haglund and debridement of the tendon with repair.
Wow. Had he got pain in the insertion place? No osteophytes, no spurs. He got pain in the insertion 8 months after surgery.
Correct. That's what the question is.
Yeah, you have to be sure that this patient doesn't have a retrocalcaneal bursitis. Some of them still have some pain because of a bursitis, and it's quite easy to give them a corticoid shot, and that's probably the easiest way to treat these patients. But you have to be sure that there's no infection and things like that. But some of them still have some pain because of retrocalcaneal bursitis.
Yeah, and I've also seen progressive Achilles tendinopathy develop. And then you have to go back in and redo your surgery, not from the Haglunds, but another debridement and maybe a tendon transfer or something else.
You consider Theta osteotomy in that case? Just
I haven't.
osteotomy.
Thankfully, that hasn't happened very often. So Zadig was not popularized at osteotomy, the last one I had, but I certainly would consider it now. So
yeah, we'll say that. What Adriana told us before, perhaps that osteotomy would be a good option for that. But I don't have experience in that osteotomy. I will start thinking in that now.
Luis and I are waiting for patients to come in so we can try it out too.
yeah, it's pretty easy, especially with MIS. All right. Well, thank you guys. It's been, that was a great session. Appreciate it. Adriana, great job.
Thank you.
See everybody back in a minute.
Thank you so much.
Thank you.
Bye-bye. Thank you. Nice to meet you, amigos.
Nice meeting you guys.